My name is Dr. Carol Benson. I work at Brigham and Women's Hospital and Harvard Medical School in Boston. I will be discussing the ultrasound evaluation of the fetal skeletal system. Ultrasound is used to assess the fetal skeletal system. We can evaluate the extremities, the spine, and the calvarium. Now, the long bones develop during the first trimester, and they begin to ossify so that they're visible on ultrasound by the end of the first trimester. By the late third trimester, the secondary ossification centers are visible in the distal femur, proximal tibia, and proximal humerus. This is a view of a 41-week femur. You can see that the calipers have been placed at either end of the ossified portion of the femur, representing the diaphysis. But you can see that, in fact, the femur is longer than that, with the epiphysis at one end, the ossification center visible in the epiphysis, and then the femoral head and neck at the other end of the bone. We can look at the fetal spine. These are two 3D renderings of the entire fetal spine on two different fetuses. Notice how you can see the matching ossification centers all the way up and down the spine. You can also see the ribs forming the thorax on either side. Now, we evaluate the extremities during our second and third trimester ultrasound. We look at the size of the long bones to look for skeletal dysplasia. We look for the presence of each of the extremities to exclude an absent limb or amniotic band syndrome. We evaluate the bones of the forearm to look for radial hypoplasia. We evaluate the hand position to exclude clenched fists, and the foot position to exclude club foot or rocker bottom foot. This is a view of a femoral measurement. You can see that the calipers have been placed at either end of the ossified portion of the femur, and we use this to assess the size of the femur for gestational age. This is the view of the upper extremity of a fetus, showing the humerus and both bones in the forearm. The ulna is slightly longer and the radius slightly shorter. And here we see a 2D and a 3D image of the hand showing the normal 5 fingers. Here you can see in fist form, here you can see with the hand open. And here we see images of the foot. We have the grayscale image of the foot showing the 5 toes of the foot, and here we have the foot and ankle on this fetus and the crossed feet and ankles on the other fetus. We assess the femur length and compare its size to norms for gestational age. The femur length should be equal to the mean plus or minus standard deviations within those norms. If the femur length falls 2 to 4 standard deviations below the mean, most of those fetuses are growth restricted and do not have a skeletal dysplasia. But when the femur length falls more than 4 standard deviations below the mean, that usually represents a skeletal dysplasia. And in most of those cases, the bones will also appear abnormal on ultrasound. So what do we do when the long bones measure too short? Well, we want to exclude a skeletal dysplasia. We want to determine if it's a dysostosis or a malformation or a deformation. This can happen, for example, with amniotic band syndrome or from a restricted uterine environment. When we suspect a skeletal dysplasia, we want to assess the degree of shortening of all the long bones, and typically they will be more than 4 standard deviations below the mean for gestational age. Then we want to look at the distribution of which bones are involved. Does it involve the extremities, the spine, the calvarium, and the ribs? And this helps us determine what type of skeletal dysplasia it is. We want to look at other bony abnormalities to look for mineralization, fractures, or bowing, and it's also important to look for polydactyly. Lethal skeletal dysplasias are those dysplasias which affect the fetus such that the neonate cannot survive after birth due to respiratory failure. And typically ultrasound makes the diagnosis of this type of dysplasia during the second trimester. The kinds of dysplasias that could possibly fall in this category, some of them are listed here: thanatophoric dysplasia, osteogenesis imperfecta type 2, achondrogenesis, congenital hypophosphatasia, short rib polydactyly syndrome. The non-lethal skeletal dysplasias, ultrasound typically does not diagnose in the second trimester, but rather these are picked up more often in the third trimester. And these types of dysplasias are not as severe. Infants can survive after delivery. A couple are listed here: heterozygous achondroplasia, osteogenesis imperfecta type 1 and 4, asphyxiating thoracic dystrophy. Thanatophoric dysplasia is the most common lethal skeletal dysplasia. It's characterized by severe shortening of the proximal long bones called severe rhizomelia. The long bones are bowed. The thorax is typically very narrow with short ribs, and the vertebral bodies are flattened. The skull has an abnormal cloverleaf shape, and often there's megaloencephaly, which is when the temporal lobe has excess sulcation and excess fissures. So here's a fetus with thanatophoric dysplasia. Notice the cloverleaf shape to the cranium. You can see protruding in the frontal region as well as protruding in the region of the temporal lobes. When we look at the thorax and abdomen of this fetus, we see how narrow the thorax is anterior-posteriorly compared to the width of the abdomen below it from anterior to posterior. This is a fetus with thanatophoric dysplasia. We look at the transverse view of the fetal thorax and see how small it is, how very short the ribs are, how the heart takes up most of the area on a cross-sectional view of the chest. On the 3D view with bony windows, we see how short the ribs are and how narrow the chest is. And on the 3D surface rendering, we can see how small the chest is compared to the abdomen and the fetal head. The long bones in this dysplasia are often very abnormal. Here we can see the left femur is bowed, the right femur is also bowed, the right humerus is bowed, and the right tibia and fibula are extremely short for gestational age. With osteogenesis imperfecta type 2, this is an autosomal recessive syndrome that is lethal. That is, the fetus cannot survive after birth. The ultrasound findings in a fetus with this type of osteogenesis imperfecta include fractures and deformities of the long bones and ribs, poor mineralization, particularly of the skull, and a soft cranium. While this is autosomal recessive, the other forms of osteogenesis imperfecta, namely types 1, 3, and 4, are autosomal dominant and non-lethal. So here's a fetus with osteogenesis imperfecta type 2. Notice the fracture deformity of the right femur with its angulation at a former fracture site. Then when we look at a coronal view of the fetus, we can see how narrow the thorax is compared to the width of the abdomen. This narrow thorax prevents the development of normal lungs. Looking at another fetus with osteogenesis imperfecta type 2, we see a very short left humerus with bowing. We can see when we look at the skull that there is almost no ossification in the skull, so that we can see intracranial contents very clearly. In addition, with gentle compression from the ultrasound transducer, we see flattening of the skull at that site because the cranium is so soft. Osteogenesis imperfecta type 1 and 4 may also be diagnosed in utero. Typically in these cases, there's lagging of growth of the long bones by the time the fetus reaches the 3rd trimester. These fetuses may also have mild fracture deformities with bowing of the long bones or angulation. They may have poor mineralization, and their skull may be somewhat soft. This fetus has osteogenesis imperfecta type 1. Notice that the humerus shows bowing instead of a nice straight diaphysis. And when we look at the forearm, we see there's bowing and angulation of the distal ulna and the distal radius. And we also see bowing of the right tibia. Looking a little more closely at this fetus, we see that the other femur also has bowing. And when we look at the cranium, we do see some ossification of the cranium, unlike the fetus who had osteogenesis imperfecta type 2. But in this case, still with gentle pressure from the transducer, we see flattening of the cranium. So the skull is still soft. This fetus also has osteogenesis imperfecta type 4. The femur on one side is normal length with a normal straight diaphysis or shaft. But when we look at the contralateral femur, we see it's foreshortened to 2 centimeters, and there's an angulation deformity due to a previous fracture. And this is just a magnified view of that fracture deformity of one of the femurs. Achondrogenesis is another recessive, autosomal recessive, lethal skeletal dysplasia. These fetuses have severely diminished or absent ossification center, marked shortening of their limbs, absent vertebral body ossification, as well as normal cranial calvarial ossification. So this fetus has osteogenesis imperfecta. When we look at the thorax, we see it small with the heart occupying most of the area on this cross-sectional view. When we look at a longitudinal view of the fetus, we see the large head, the very narrow thorax front to back, and then it looks like the abdomen protrudes, and that's only because relative to the thorax, it's quite large. Looking at the long bones, we see an angle deformity of the radius, angle deformity of the femur, and marked shortening of the tibia and fibula with bowing. This fetus also has achondrogenesis. Notice how small the thorax is compared to the abdomen. You can see it on the sagittal view of the fetus, but you can also see it on the 3D image of the fetus showing a small thorax and protruding abdomen. And here you can see the measurement of the thorax compared to the abdomen from anterior to posterior is markedly different. Another type of skeletal deformity is something called arthrogryposis, which is not in and itself a diagnosis, but rather it's a description of a fetus who has multiple joint contractures. And this can develop from a variety of etiologies, can develop from limitation to motion in utero, such as from oligohydramnios or a multiple gestation or a bicornuate uterus. It can also develop from abnormal nerve function, abnormal musculature, or defective connective tissue. With arthrogryposis, the findings on ultrasound include multiple contractures, intrauterine growth restriction, often there's polyhydramnios, and there may be hydrops due to lack of movement of the fetus. This fetus with arthrogryposis has abnormal posturing of the lower extremities. You can see fixed hyperextension at the knees. You can see that the feet are both turned in and persistently flexed. When we look at each leg on its own, we can see that there are club feet at the end of each of these legs due to the contractures. This is a different fetus, but another one with arthrogryposis. Notice the abnormal posturing of the hand here, the right hand in this 3D view. And notice the abnormal posturing of the foot. It was persistently pointed forward. And here you can see what that foot looked like at birth. This fetus has Larsen syndrome, which is another cause of arthrogryposis. This is a rare genetic syndrome characterized by contractures. Notice the hand and its abnormal posturing, and the foot with a rocker bottom and abnormal posturing, and how the leg is hyperextended up over the body. The 3D view tells everything. You can see how the legs are abnormally extended up over the fetal abdomen with hyperextension of the knees, abnormal motion at the hips, and abnormal positioning of the feet at the end of the legs. This fetus had persistently clenched hands secondary to in utero exposure to cytomegalovirus. Notice in the head we see ventriculomegaly and intracranial calcifications, and these hands remained flexed throughout the entire time of the ultrasound. The feet were also abnormal. There were bilateral club feet, but not the typical club feet. They were turned upward, not just turned inward, and had unusual positioning of the feet. Here they are, 3D ultrasound prenatally. Here they are immediately after birth, showing the same abnormal positioning of both of the feet. Now we also look at the upper extremities closely. We look for abnormalities of the hands and the forearms. Abnormalities may be inherently present due to malformation or dysplasia from the beginning of development, or they may develop later on in gestation, affected by external factors, such as uterine constraints or amniotic bands that cause deformations, or disruption during development from a teratogen. One of the most common abnormalities of the forearm and arm are radial ray anomalies. These are associated with lots of syndromes, so if you do see a hypoplastic or agenesis of the radius, do look carefully at the rest of the fetus because it may have one of these other syndromes that are listed here. It also can be associated with trisomy 13 or trisomy 18. This abnormality of the thumb was part of the Vochteral syndrome, which is an anomaly characterized by anomalies of other parts of the body, including the heart and the kidneys, as well as the vertebral column and the radius. So here we see abnormal attachment of the thumb to the hand. When we look at the heart, we can see that the aorta is overriding and widened. This baby had a tetralogy of Fallot, and there was a two-vessel umbilical cord. This is another fetus with the Vochteral syndrome. This one had a hypoplastic radius. You can see that the radius is foreshortened and the ulna is bent around that short radius. Here we can see we've measured and pointed out the small abnormal radius here. This fetus also had a cardiac defect, double outlet right ventricle, which we see here in the parallel outflow tracts from the transposition of the great vessels. This is a fetus with trisomy 18 who had absence of the radius on both sides. Notice that the humerus appears normal, the ulna is foreshortened, and then the hand is turned and rotated inward to lie on top of the forearm. And the same was true on the other side. This is a magnified three-dimensional view of the bones of the upper extremity showing the humerus, the ulna, and the hand turned over to collapse on top of the forearm. Now, limb reduction defects are those defects where there's some part of the extremity missing. The terminal transverse deletions are those that are missing from one point onward. These may be seen such as when there's an absent hand. Very often these are isolated anomalies that are sporadic. They're usually unilateral. They may result from amniotic band syndrome or from a vascular accident. But sometimes these limb reduction defects result from syndromes, such as an oral facial syndrome like Poland syndrome, or again from amniotic bands. This fetus is missing a hand. Notice on the grayscale ultrasound we have the ulna and the radius, and then just a little nubbin on the end. With the 3D, we can show the surface rendering of this upper extremity to show the parents what the upper extremity will look like. And you can see that there's just a nubbin where you would expect the hand to be. We can take that 3D volume and look more closely at the bony structures inside it. This is that upper extremity. We can see that the humerus, ulna, and radius are intact and that there are at least 4 carpal bones, which means that the surgeons postnatally will be able to create a wrist out of this small nubbin that exists. This fetus is missing part of the forearm and the hand on the left side. Notice the right arm and hand are normal, but the left arm has a normal upper arm, but only half of the forearm and no hand at all. On bony windows, we can see exactly how much of the radius and ulna are still present before the truncation partway down the forearm. Polydactyly is when there's an extra finger or a toe. Polydactyly in and of itself does not cause problems postnatally, but it is often associated with other syndromes or anomalies, and therefore we need to look closely at the fetus when we see this finding. The skeletal dysplasias associated with polydactyly are short rib polydactyly, chondroectodermal dysplasia, asphyxiating thoracic dystrophy. We can also see polydactyly with trisomy 13, Meckel-Gruber syndrome, and sometimes polydactyly is just an autosomal dominant trait with no other syndrome or anomaly, and this is usually when it's post-axial, that is, next to the little finger or little toe. This is a fetus who has polydactyly with Meckel-Gruber syndrome. Notice on the clip through the hand, the extra digit next to the little finger, and then when we look at the foot, we can see that there are 6 digits across the top of the foot. This fetus also has polydactyly with the extra digit sitting in front of the little finger. Here we see a thumb and 4 normal fingers. Here we see it here, and then in front of the little finger is an extra digit. On the clip, you can see it kind of protruding to the side a little bit of that little finger, sometimes it just sits in front of that little finger. And this fetus has a duplicated thumb. You can see on the clip that the thumb is too wide with too many bones. And on the 3D, you can see how wide the thumb is with extra bones here and here. Extradactyly is a term for a claw-shaped or cleft through the middle of the hand or the foot, typically characterized by missing digits, sometimes with syndactyly of the extra digits remaining. This can be associated with genetic syndromes such as split hand foot malformation, Silver-Russell, or Cornelia de Lange. Here's a fetus missing the middle finger with a cleft right down the middle of the hand. You can see the cleft on the still image. You can see the cleft on the clip. But when we do the 3D, we actually get the bony window and clearly see the thumb, the index finger, and the little and ring finger with a cleft running down the middle, missing that middle finger. This fetus has cleft hands. Here you can see cleft foot. Here you can see a cleft in the middle of the foot. Here on the view of the bottom of the foot, we see a large cleft. And here on the 3D, we see that defect right in the middle of the foot. When fingers overlap and don't sit in their normal position, it's called clinodactyly, or overlapping digits. And this is due to deviation or deflection of the fingers, often curving inward. So the fifth finger may curve towards the fourth finger, and this may be seen with trisomy 21. Or you may have overlapping digits with trisomy 13 or 18. This fetus has an overlapping finger just on one hand. So the left hand was completely normal, but the right hand had persistent overlap of the second over the third digit. So this is abnormal and should not be like that, but this was an isolated anomaly that was not associated with trisomy 18. But this fetus does have trisomy 18. Notice all of the overlapping digits. The little finger and the index finger both overlap the fingers adjacent to them, as we see here and here. And if we look here, we can get a closer look at that overlapping index finger over the middle finger. And this fetus has very short fingers. This is called brachydactyly. Notice how easy it is to recognize how short they are on the 3D view. Club foot can occur as an isolated abnormality or may be a component of a genetic syndrome or may result from environmental pressures in utero, such as severe oligohydramnios or a uterine anomaly. The ultrasound findings are characteristic. We see the bones of the foot lying in parallel to the bones of the lower leg. So here we have a 13-week fetus where we see the bones of the lower leg and the bones of the feet in the same plane. We suspected a club foot, but this is a very early gestation to make that diagnosis. And so when she came back at 21 weeks gestation, we now could confirm the diagnosis. We now see the club foot on 2D ultrasound, the bones of the feet lying in parallel with the bones of the lower leg, and seen even better on the 3D ultrasound with the surface rendering showing the turning in of that foot, and the bony reconstruction showing the bones of that foot lying in parallel with the bones of the lower leg. Another foot anomaly we sometimes see is a sandal gap deformity. This is when there's abnormal prominence of space between the first and second toes, and it can be seen with some chromosomal abnormalities such as DeGeorge syndrome with 22q deletion or trisomy 18. So here we have 3D images from a fetus with the sandal gap deformity. Notice the prominence of the space between the first and second toes. Here and here. Here we have both feet, so you can see it's affecting both sides. Here's just a slightly different angle of that view. We also look at the long bones. An anomaly we pick up could be something called proximal focal femoral deficiency, when there's shortening of one of the femurs, but the other femur is normal. Now there may also be other skeletal anomalies, typically on the same side as the abnormal femur. So here we see a normal femur on the left with a nice normal shaft. And here we see bowing and shortening of the right femur. And on the 3D, we can see how nice and normal the left femur was and how very abnormal the right one was, with curving and bowing and shortening. This is that fetus after birth. You can see that on the normal side we have the femoral neck and head and the greater trochanter, and on the abnormal side we're missing the greater trochanter and the femoral neck, and so it's foreshortened and bent as we see here on the x-ray and compared to the normal left side, just like we noted in utero. With amniotic band syndrome, there's early rupture of the amnion. Fibrous bands then entrap and adhere to the fetus, leading to limb amputations or deformities and other disruption of the fetus, including encephalocele, facial clefts, ventral wall defects, and we can even have ectopia cordis. Now on ultrasound, we'll see a variety of deformities. They're all different. It doesn't follow a true syndrome in that no two cases are the same. We may see deformities of the skeleton, the cranium and face, the ventral wall. We may have a clue as to the reason for the abnormality if we can see the adherent bands extending from the edge of the gestational sac to the fetus. Now these should not be misdiagnosed as amniotic sheets. So here's a fetus with amniotic band syndrome where the amniotic band is entangling one of the hands. Notice this hand is very abnormal. When the fetus moves, you can see a band traveling with it as it moves away from the wall of the uterus. And on 3D, we can see how malformed that hand is, missing some fingers as well. And this fetus has amniotic band syndrome. The band must have encircled the leg but not caused an amputation, so we see an indentation all the way around this leg. Here you see it in still image. But this fetus did have an abnormal foreshortened right foot. Part of the assessment of the fetal skeleton involves looking at spinal abnormalities. We can see meningomyelocele, hemivertebrae, scoliosis, diastematomyelia, caudal or sacral regression or agenesis, and sacrococcygeal teratomas. When a meningomyelocele is present, there's disruption of the posterior elements of the spine as well as the skin over the spine. Normally, the spine has 3 ossification centers that make a C shape. When there's a meningomyelocele, the posterior elements are splayed laterally. There's a defect in the skin, and a mass or dorsal sac protrudes from the spinal canal out behind the fetus, as we see here. Here are images from a fetus with a meningomyelocele. On a transverse view of the lower spine, we can see a cystic structure protruding posteriorly. This represents the dorsal sac. On the sagittal view, again we see the dorsal sac, but we also see disruption of the bony elements of the spine in the distal spinal region. On the 3D view of the same fetus, we see widening of the spinal canal distally due to the meningomyelocele with splaying of the posterior elements. On the 3D, we can identify the level of the meningomyelocele. This one begins at L5S1. This is another fetus with a meningomyelocele. This was a much more subtle spinal defect on ultrasound, but we had a clue that there was a meningomyelocele due to the changes in the fetal head. On an axial view at the level of the ventricles, we see the lemon-shaped contour to the fetal head with concavity and flattening of the frontal bones, and we see the banana shape to the cerebellum in the posterior fossa due to the Chiari-2 malformation. Doing a 3D ultrasound of the spine, we saw no abnormality. We don't see splaying of the posterior ossification centers, but a careful clip through the distal spine in this fetus showed us that spinal defect with absence of the skin and slight splaying of the posterior elements. This was an open defect, so it's the absence of the skin and the protrusion of the posterior elements at that level. A meningocele is a less severe form of spina bifida. If there is a meningocele, you will have a spinal defect, but only fluid and membranes will protrude from the spinal canal. No nerve roots will be involved. These are often skin covered, and therefore the maternal serum alpha fetal protein will be normal. On ultrasound, we will still see splaying of the posterior elements, and we'll then see a cystic mass protruding posteriorly from the fetus. So here's an example. At 19 weeks gestation, we see when we look at the fetal head that the posterior fossa is normal. There is no Chiari-2 malformation. There is no effacement of the cisterna magna. When we look at the spine. On longitudinal view, it can look normal in some views, but on a direct sagittal view, we see disruption of the posterior elements with a cystic mass protruding posteriorly from that area. And on transverse view, we see splaying of the posterior elements with a bit of protrusion of cystic lesions from the spinal canal. This is another meningocele. We can see that protruding from the back of the fetus is this cystic mass. It does travel into the spinal cord, but only by a narrow stalk. Here you can see the path of that meningocele and its narrow stalk out of the spine. This was just a meningocele. Notice that the posterior fossa of this fetus is completely normal with no Chiari-2 malformation. Now, hemivertebrae are when there's segmentation abnormalities of the spine where there might be two posterior elements on one side and one on the other. These are associated with a variety of syndromes. On ultrasound, we'll see a kink in the spine with mismatch of the posterior ossification centers. This fetus has hemivertebrae in the distal lumbar spine. You can see that there's a kink in the lumbar spine on longitudinal view, and if you count the posterior ossification centers, you see there's a mismatch with an extra one located here after we've matched the other pairs. When we do the 3D rendering with the bony windows and reconstruction, you can see this is the hemivertebrae. Here there is one ossification center on one side, and there are two on the other side with a single vertebral body. So this is a hemivertebrae with the extra one on one side. This fetus also has a hemivertebrae. You can see up here at L1 that there are two ossification centers on one side and one on the other. Slightly different views here and here. This fetus also happens to have 13 ribs, as you can see here. Now, an unusual anomaly of the spine is something called diastematomyelia. This is when there's a bony or cartilaginous or fibrous spur that bisects the spinal canal and the spinal cord. This can cause a tethered cord if it's not treated shortly after birth. On ultrasound, we'll see widening of the spinal canal and, in some cases, a neural tube defect associated with the diastematomyelia. So here's a fetus with diastematomyelia and a meningomyelocele. You can see marked splaying of the posterior elements, but you can also see a bony spur between the posterior elements. This is representing the spur that splits the spinal canal. Here on 3D, you can see the entire thing with splaying of the posterior elements and that extra bony spur. And here's what it looks like after birth. Notice the marked splaying that we see on the X-ray, almost identical to what we saw prenatally. Sacral agenesis is a complication found in fetuses of diabetic mothers with poor glucose control. It's characterized by hypoplasia or absence of two or more of the sacrovertebrae. On a longitudinal view of the spine, when we follow the spine down, we see that we're missing some of the ossification centers here, and there's disorganization of the ones just above the region of agenesis. And when we look on the X-ray after birth, it looks just like the prenatal findings with disruption of the ossification centers above and then missing ones below. This fetus has 4 lumbar vertebrae and no sacral vertebrae. L1, L2, L3, L4. And L4 has a triangular shape, and then it converges on the 2 iliac crests because there's a complete absence of the sacrum. This was the prenatal view. Here's the postnatal view. Looks just like the prenatal view. Lumbar 1, 2, 3, triangular shaped 4, and the iliac crests. Evaluation of the skeletal system also should entail looking at the cranium. Cranial anomalies can be found and can be associated with other abnormalities of the fetal skeletal system. One of the most common cranial anomalies is craniosynostosis, which is early closure of the sutures. This can come in several forms, like trigonocephaly with trisomy 13 or a cloverleaf skull with thanatophoric dysplasia. Another cranial anomaly is the lemon sign. This is a complication of the Chiari-2 malformation, and we can have a strawberry skull with trisomy 18. With cranial synostosis, there's premature closure of one or more cranial vertebrae, cranial sutures. This occurs more often in males than females. The complications lead to abnormal head shape, abnormal faces, neurologic deficits, and even sometimes hearing loss. The prenatal diagnosis cannot be made in the second trimester and often not even in the third trimester. This is a case of craniosynostosis that we did diagnose in utero. At 34 weeks gestation, we noticed that the fetus had a pointed skull instead of the normal oval shape to the frontal portion of the cranium. Here we see it on two different views. With trigonocephaly, there's craniosynostosis as a result of premature fusion of the metopic suture. That's the one anterior midline towards the forehead. And it's this type of craniosynostosis that's associated with trisomy 13. So here's a fetus with trisomy 13 and trigonocephaly. Notice the pointing of the front part of the fetal cranium, as we see here. This fetus also had semilobar holoprosencephaly, so there was fusion of the lateral ventricles across the midline anteriorly. A cloverleaf skull is what we'll see with things such as thanatophoric dysplasia. It's from craniosynostosis causing a trilobe shape and a very prominent forehead. This is a fetus with thanatophoric dysplasia that has something of a cloverleaf skull. We can see a little bit of bulging in the region of the temporal lobes and a little bit of bulging anteriorly here on the axial view, but a little more prominent bulging of the forehead on the profile view of the fetus. Now, a lemon-shaped cranium is one that's often seen with the Chiari-2 malformation that's seen with a meningomyelocele. It's characterized by flattening or concavity of the frontal bones, leading to a lemon-shaped skull. You can see on this fetus, who has a meningomyelocele here and a protruding dorsal sac, that the cranium has the shape of a lemon, with flattening of the frontal bones and a pointed anterior portion of the cranium. This fetus also has ventriculomegaly. The strawberry-shaped cranium is associated with trisomy 18. Here is a fetus who has a strawberry skull. There's flattening posteriorly and then almost a triangular shape to the front portion of the cranium, leading to the shape of a strawberry. And this is commonly seen with trisomy 18. This is another fetus with trisomy 18. Notice the strawberry shape to the skull, flattening on the sides and flattening posteriorly, giving it almost a triangular shape. This is a 3D of the same fetus showing the very abnormal posturing of the hands characteristic of trisomy 18. This is a picture of a fetus telling me to stop. I've come to the end of my discussion of ultrasound of fetal skeletal abnormalities, and I hope this will help you in your practice. Thank you.